Thank you, and thanks for sticking around for the last panel of the day. Of course, we're going to be talking about Cannabinoid Hyperemesis Syndrome today. This is something that has come up in the media quite a bit. They say there are no deaths from cannabis, but ultimately this is one of those things where sometimes the complications of cannabis use can result in death. And it is a really sad thing that we see out there. It doesn't happen with very many folks, but it is something that is continuously coming up. And so we have some esteemed panelists here with us today, of course, Dr. Dorr, who just gave his talk, and Alice Moon and Tom Folan. I will do a bad job of introducing these folks properly, so I'm going to let them give them their own introductions. Dr. Dorr, if you'd like to start.
Okay. Thank you. Well, it's so helpful. My name is Dr. Michael Dorr. I'm a family physician, and for the last 6 years, I was the senior medical director of the cannabis program of the Israeli Ministry of Health.
Amazing.
Good evening, everyone. Thanks for sticking with us. It's pretty late, so we'll try and make this short and painless for you and not induce emesis. My name is Tom Folan. I'm a board-certified diagnostic radiologist who has established a cannabis medicine practice with a focus in glioblastoma patients. And I'm happy to be here to talk to you about cannabis hyperemesis.
Hi, everyone. Here, let me get right there. I am Alice Moon, and I have been in the cannabis industry for 8 years. And we are here right now because I have Cannabinoid Hyperemesis Syndrome, which means basically cannabis makes me violently ill. So CHS is a condition to be believed to be a side effect of frequent and long-term cannabis use, and the side effects include nausea, vomiting, and abdominal pain. So today I'm going to tell you guys my story, and hopefully it'll inspire you guys to help me find a cure for this. So I've been in the industry for 8 years, and when I was working at a dispensary in 2015, I was writing product reviews. So I would consume edibles and write about it. So I was having about 10 milligrams of edibles a day. And then in 2016, I started throwing up. And at first it was pretty random. Every few months I would just puke and couldn't figure out why. I felt normal, and doctors couldn't figure out why either. They said I had acid reflux, so I changed my diet. Kept getting worse. Then I stopped drinking alcohol, even though I wasn't drinking a good amount. I thought maybe that has something to do with it. And I didn't have alcohol for 2 years. And during that time, I was getting worse and worse to the point where in 2018, I was starting to throw up almost every day. I saw a specialist who said it's cannabis, and I didn't want to believe it. I'm sure most of you don't want to believe it because we know that cannabis helps with nausea. So how could something that helps us with so much also do damage? So I said, okay, I'll take a cannabis break, but first I'm gonna have my last hurrah. So I went to a 5-course infused dinner, and that triggered my first episode of 14 days of nonstop throwing up all day, every day. Now, at this time, I knew nothing about CHS, and I felt like I was dying. I just wanted it to end. I didn't know what was happening. It was just throwing up over and over and over and over. Even a sip of water, I was throwing it up. Now, the interesting thing with this syndrome is the one thing that stops the throwing up is hot baths or capsaicin cream on your stomach. Now, that's a cayenne pepper-based cream. So I first tried this cream, not knowing what it was, put it all over my stomach, and then my skin was on fire. So I was in excruciating pain, but I wasn't throwing up. So it was like, okay, what do I want? Do I want to have my skin on fire, or do I want to be puking? Ultimately, I chose the puking because it was too much. And so then I was in the bathtub and trying out the bathtub route, and that helped a lot, but it dehydrated me as well. And the second I would get out of the tub, I was throwing up. So I slept in my bathroom on my bathroom floor for many of nights. My roommate would come home and check to make sure I was even alive. I passed out in my front yard one day because I was throwing up so much that I couldn't hug the toilet. And a neighbor stopped by and said, "Can I help you?" And I just broke down and cried and said, "I wish you could. I wish somebody could help me. I don't know how anyone can." And, you know, I felt like I was dying. Everyone around me was extremely scared. I lost 15 pounds. And so then I quit using cannabis for 3 months. Now, people were saying they thought that this was pesticides. So after taking a 3-month break, I said, okay, let me use pesticide-free cannabis. Tried that, and it came back. That time, it only lasted 4 days, so not as terrible, but still not very pleasant. So then after that, people were saying, CBD, try CBD. I'm sure CBD will work for you, right? Like, it has the opposite effect. It'll totally work. Okay, I tried CBD, and that ended up triggering my worst episode yet. It was on December 22nd, so I didn't get to enjoy Christmas or New Year's. I threw up all day, every day for 16 days. I had 2 urgent care visits, 1 at-home nurse visit, and ultimately was in the hospital and was in there for 4 days. And, you know, my ER doctor didn't even know the difference between THC and CBD. Isn't that fucking ridiculous? Like, excuse my language, but that is absolutely ridiculous that an ER doctor wouldn't know the difference. So they can't even, know that cannabinoid hyperemesis is real. And in that process, I got 2 ulcers, a hernia, and a bacteria infection. Now, I'm proud to say that I've gained 30 pounds since my hospitalization, and I think that really speaks volume to how much weight I lost in the beginning of the year. It was extremely scary, and I was near death. And I don't want anyone else to go through what I went through. And what's pretty crazy is I was looking to see when was the last time I had THC? When was that last episode? And I realized that September 24th of last year was actually the last time I had THC. So I think it's pretty serendipitous that right now is my 1-year anniversary of no THC. Now, I want to be clear that I was like one of you before. Cannabis is my life. I love weed so much. It is my whole entire world. I'm a publicist in the cannabis industry. Before I got sick, I was going to 3 to 5 events a week. It's my life. And now I can't even be around secondhand smoke. So now I am determined to find a cure for this. No one's researching it, and I want us to figure it out so no one else has to get this sick, and so I can smoke weed again.
So I want to preface this with thank you, Alice, also for sharing that story. It really kind of gives some color to what we're dealing with out there in terms of this condition. I do want to mention that there is not a lot known about this condition currently, so I will advise that not all the panelists have every single answer, but we're going to do our best to tackle it today with this discussion. So I guess I'll start with the first question I have for the panelists, and that is, so the first cases of this started to emerge in around 2004, and it's taken a while for the medical community to actually acknowledge and recognize this condition in the first place. So I'm hoping to get some insights from our panelists as far as why you think that is. Why is it that the medical community has taken so long to actually recognize this condition?
Sure. So thanks again to Alice for sharing her story. It takes a lot of courage to come to a conference like this where basically people are celebrating a certain thing and you've had this terrible experience with it. And just, to kind of confirm what she's saying, I remember as a first-year resident in Chicago, was the first time I ever heard of this. I had graduated medical school, and to Alice's point, had never even heard of such a thing. And I remember at Cook County in Chicago, where I was doing my training, the ER doctors were, ordered a CT scan. They're like, it's going to be negative. We see this kid every few months. He smokes cannabis. CT scans never show anything. And of course, the taxpayer is picking up that bill. He's picking up all that radiation for something that we now know to kind of screen for and look for in patients coming in who endorse a history of chronic cannabis use with this nausea and vomiting. So to Kyle's question, the first case is showing up in 2004. That's correct. That was from Allen et al. In Australia in a case of 9 patients who endorsed a history very similar to what Alice has talked to us about. And upon cessation of cannabis, I believe 7 of those patients had complete recovery. And so this was the first time this became percolating to the surface of the medical consciousness. Does that mean that we haven't had cases of CHS, or so-called CHS at least, prior to 2004? No, it does not. But of course, in radiology, we have a very famous saying which says, the eye does not see what the mind does not know. So you could be looking at patients all day long who are throwing up. If you don't know that there's an entity called Cannabis Hyperemesis Syndrome, which involves TRPV1 receptors that we'll get into and CB1 receptors, you're not going to even know, it's not going to be on your radar. And another point we'll get into is there's this second entity called CVS, of course. It's very non-confusing, CVS, CHS, cyclical vomiting syndrome. These patients will typically have the exact same presentation, nausea, vomiting, abdominal pain, except that a good percentage of them as well will also endorse a history of migraine. They tend to be more female than male, which is the opposite with CHS. And then we don't quite see the striking use of a hot water bathing that we do see in CVS. But the reason I'm mentioning these are CHS, with CHS, thank you, Alice. But the point being that there's an awful lot of overlap. And so, in fact, one of the latest papers I read from May of this year actually thinks that CHS may be a particular subset of CVS. And so just bringing this up in the context of this question, because CVS was known before 2004, okay? So I think these are some of the factors. And then maybe a final factor that people like to talk about is this increasing potency. We now have concentrates and other forms of cannabis that are, 90% THC and beyond, and that perhaps this bombarding receptors over time at this level could potentially account for the increase in prevalence of these cases.
And also, people are now admitting to their doctors that they're using cannabis. A lot of people are afraid to talk about it, so doctors wouldn't even know. If someone's not, they just don't know. So now that states are legalizing, and cannabis is a hot topic, and a lot of emergency room doctors in, Colorado, they know about this, so now they're documenting it. And there's been cases of this all over the world. I have talked to thousands of people with CHS. All over the world, people have it. It's just no one's keeping track of it, and no one's really putting forward the effort to talk about it.
I think the same as my colleagues. I tried since the morning to check the numbers, and I was given a number which was a surprise to me. We have almost between 200 to 300 cases like that. I mean, all the hospitals together in Israel. But let me refer to something, because I would like to see things in larger scale. This is only one of the syndromes connected to cannabis that are underreported. We don't have a good report system about side effects. Then, when we don't have the system, we cannot publish results, and the physician does not know about it in emergency room. So the beginning should be teaching physicians and teaching again.
And just to build upon Dr. Dorr's point, because it's a great point, how we gather the data and how we're characterizing things is very important. So when we say someone's a heavy user, what does that mean? Is that 4 times a week? Is that twice a week? These things matter. And so another point that I'll raise is that the current Bible of gastroenterology is known as the Rome 4. So in psychiatry, we have the DSM-5, which is the Bible, and that contains cannabis use disorder. The Rome 4 contains CHS, Cannabinoid Hyperemesis Syndrome, but even that is an imperfect tool for use, and this paper that I just read from May of this year suggests improvement upon this, so that when a patient has stopped using cannabis for a period of 6 months and has had complete cessation of these symptoms, they're proposing that we use that 6-month period, because the Rome 4 didn't give any time period. So a patient could stop for a month and not have any symptoms, and then go back on cannabis and then have symptoms again. So the point is that even with this entity, how we're diagnosing it and who we're going to include is evolving all the time, and it's as well it should be, because the major point's that if you've been off for a month, that actually isn't long enough to be able to tell if you're going to have another cycle. So the proposal is that even the Rome 4 criteria aren't good enough, that we need to be iterating on that and editing as we go along.
And so to follow up with what Dr. Dorr just said, since this morning when he just did a few simple phone calls, he discovered that there's 300 people in Israel that they have documented. At the end of this presentation, we are going to be going over, I have talked to 200 people. Well, I've talked to thousands of people, but I have statistics from 200 people. And we will be going over the data that I have collected. And so this just shows how widespread this really is. And it's a lot bigger of a deal than we're currently acknowledging it to be.
So we spoke a lot here about basically what are the issues in terms of how people are identifying this. So because there seems to be this kind of confusion among practitioners as far as how to actually make this diagnosis, what would you say would be the best approach to actually make a confirmed diagnosis of CHS?
Sure. So I kind of spoke about it in my prior answer, but I'll go to it again. A modified version of the Rome-4 is the best criteria we currently have. So that requires that you have a history of using cannabis for at least 1 year, that what they're defining heavy use or frequent use is greater than 4 times per week. They didn't give a defined time period for cessation of cannabis and resolution of symptoms. So what Venkasathon, I believe the paper is from May of this year, is proposing is that you wait for a period of 6 months after cessation of use, or 3 cycles of hyperemesis. So if that patient would, on average, go into a hyperemetic phase every 5 weeks, then at 15 weeks after cessation of use, you could now apply that diagnosis retrospectively. And the reason this is very important, we want to get the point out that someone shouldn't be walking into the emergency room saying, I use cannabis and I'm throwing up and I get relief from showers, and then having that label applied to them. Because what they're finding is that a good percentage of patients who have CVS, the cyclical vomiting syndrome, and psychogenic vomiting and other forms of nausea and vomiting also find relief from hot bathing, not at the high percentages that we're seeing being reported in association with CHS, but certainly it is there. So again, I want to harp on that 6-month and or 3 cycles of hyperemesis, that from the time you've stopped, and that brings us to our next caveat. CVS patients and CHS patients, up until they develop these symptoms, CVS patients use cannabis actually to treat their cyclical vomiting. And so they don't want to stop. And so trying to tell these people to stop for a period of 6 months, what ends up happening is they don't stop. And maybe they don't tell their doctor about it because they don't want their doctor to get angry at them. And so this paper then goes on to talk about how if the patient doesn't stop and has used for greater than a year and has used greater than 4 times a week, that a tentative diagnosis of CHS can be applied in that case. But again, I will point out that this paper was very much in one case series where they looked at when they applied Rome-4 criteria retrospectively, they found that a good percentage of patients who had been labeled with CHS in the emergency room no longer fit the criteria for that diagnosis.
All right, that was actually, let's Dr. Norwood.
Just one more consultation I did today was I asked Professor Meshulam about our guru, and his answer was give such a patient more THC. I said I wouldn't dare.
No. No.
No.
And this is the godfather of cannabis, and it's just he knows so much, but this is something that people don't know about. People don't know about this. We need to have a chat with him. I know he's back on a plane to Israel, but we're going to have a chat for sure. But yeah, the next question that you were going to go over was the treatment once people get this.
Yeah, so I mean, we've made a diagnosis now. So what are the first lines of treatment that you would actually propose to give to someone who has been formally diagnosed with CHS? Go ahead, please.
So capsaicin cream on the stomach, that helps, that relieves the symptoms. That relieves the symptoms for a lot of people. And then the antipsychotic medicine, Haldol, that has had a high success rate of stopping the nausea and vomiting. But the side effects of it are so severe that the people I've spoken with have all said they would rather be vomiting. Because it's an antipsychotic, it has caused a lot of anxiety, hallucinations. People don't understand what's going on with them because most of the time doctors aren't explaining the medicine that they're giving to them. And so all of a sudden someone's going through like this feeling of psychosis in the emergency room and they don't know why. So really the only thing is like for people to stop using cannabis, but an IV and capsaicin, and that would be it. I mean.
Yeah, so Alice brings up a great point with capsaicin. In fact, some people, you figure this could kind of be diagnostic. So you come into the emergency room, you endorse a history of cyclical vomiting and using cannabis, and they rub a little on your chest and abdomen. If you start to get better, they shouldn't apply the diagnosis right then and there, but it's kind of presumptive a little bit, because as we're going to talk about probably in a little bit, the receptor where we were initially focused on was CB1. As things have evolved and we've learned more about this need for nociceptive heat above 41 to 43 degrees centigrade and the use of capsaicin, we focused on the so-called capsaicin receptor, TRPV1. And so that's why that can be helpful. But in some patients, it's not. That's why Alice mentioned, why would we give an antipsychotic such as haloperidol, common name is Haldol? Because guess what? Our ondansetron, our 5-HT3 drug that works for our chemotherapy patients, famously does not work in this case. Reglan, our metoclopramide, which is another medication that we will use for various patients with nausea and vomiting, also doesn't work universally. Now, in an emergency room, your average ED physician are going to try and go to these things before they go to haloperidol, typically, because haloperidol can cause tardive dyskinesia, that famous lip smacking and other things that Dr. Meshulam talked about yesterday in his talk on schizophrenia, where he was saying, hey, we could use CBD in many of these patients and avoid these nasty side effects. And of course, the other issue being that some patients develop this tardive dyskinesia from the very first administration. So, ER doctors don't take it lightly to administer this. But the other thing that I will mention is that haloperidol works so well that when it stops the nausea and vomiting, in this case as well, that's another a sign that that's potentially what we're looking at. But again, bear in mind that 6 months, 3 cycles before you're applying that label, which will now stay with that patient for life. And of course, I should also famously say, biggest things, basics in medicine, get fluid into these patients. They are throwing up. So the initial treatment in the emergency room is IV fluids, sometimes benzodiazepines to sedate the patient, to take them away from this hellish experience they're having, getting fluids into them, stopping the emesis by any of the methods that we can. I've mentioned 5-HT3, I've mentioned dopamine antagonists, haloperidol. So emesis is a very complex mechanism, and we will try any and all of our drugs to shut it down and prevent the patients from going into acute renal failure, which has happened.
And acute renal failure kills you. It can. And so, just so you know, there have been deaths from CHS, but we can get towards that towards the end.
You mentioned that in the morning, and I wonder, the deaths from CHS must be because of dehydration. Mm-hmm. And
yes.
I find it hard to believe in the 21st century, a medicine that does not know to treat dehydration. Unless those patients didn't come to the hospital, of course.
Part of the problem, Dr. Dorr, and there was Alex Berenson, who I'm sure is known and loved to all of us in this room, recently, or last week, was publishing a case from Indiana where a young guy had died with this presumptive diagnosis of CHS, but it gets to a point I talked about earlier. When people associate cannabis with anti-emesis, you coming along and telling them that this very thing they're using is called, he didn't believe it. And his own mother was there crying. He kept on using, and he didn't believe it, and he tried stopping, but he went back to it. So I don't want to blame patients here, but we're all humans, and it's human nature. So that's why it's important that we're having these discussions and raising this awareness. And absolutely, in the 21st century, to think that someone dies from dehydration, but unfortunately, this is what happens.
Yeah. I mean, and some people are afraid to even go to the hospital, and some people can't afford to even go to the hospital. I mean, my urgent care visits were expensive, and I have insurance. This syndrome has cost me a lot of money.
Change the system.
I'm going to change the system. That's why we're here, Dr. Dorr. We are going to change it.
So I do want to ask about treatment, right? So we talked about different drugs that can be used to treat it, but we're also hoping to understand what can we use otherwise, like supplements, things like that. What other activities can we use to mitigate the symptoms of CHS? And then also, are there any types of triggers that you've noticed? Of course, we know cannabis is a trigger, and not just limited to THC, as Alice mentioned. She also had an episode with CBD, and there may be other cannabinoids implicated as well. But specifically, what kind of triggers are out there, and then also what other types of strategies have you been using to mitigate, aside from the drugs that Tom had mentioned?
Well, one interesting thing is running helps a lot of people stop throwing up, and there's one reported case of somebody getting rhabdomyolysis from running for 15 hours straight. 15 hours, but he wasn't throwing up. And so I thought that was pretty alarming. So, I reached out to my network of people with CHS, and we'll go over the stats later, but 20 people out of the 200 found relief from running. So that is another thing that people have found relief from. Some people are taking vitamins. I personally, I don't have any, I don't use cannabis at all. So that's kind of how I try to deal with it.
I was just going to say, just to build on what Alice is saying, in case any of you are wondering, well, how does running tie into this? This all gets back to the TRPV receptor. And what they think is going on here is a cutaneous steal syndrome, where basically you're having dysfunction with CB1 receptors at the level of the bowel. And when you put yourself under a hot shower and get that 41 to 43 degree temperature, hitting the TRP receptors, which have been desensitized, they now open up and allow you to feel anti-emesis or a normal level of just functioning. But interestingly, when the patients run, you're doing the same thing. Or what I should have said there is, when you're in the shower, all of your blood is flowing to your skin to release heat, so it's pulled away from the bowel. They think that the mechanism underlying the running is that when these patients are running, all of their blood is now going to their muscles and not to the bowel. So it's this cutaneous steal or enteric steal syndrome. And again, this is all hypothesis, but this is the current best understanding of why this occurs.
And as far as triggers, well, there's quite a few foods that people can't eat if they have CHS. Now, not everyone. Thankfully, these foods don't affect me, but black pepper, coffee, and chocolate, they have naturally occurring cannabinoids in them, and it can trigger someone to have an episode of CHS. Some people literally cannot touch black pepper at all. Now imagine trying to go out to eat at a restaurant and trying to ensure that your food doesn't have black pepper. That's not easy. I think those are the most popular foods that are the triggers for it. Do you have any others?
No, and of course that makes sense just with beta-carotene having cannabinoid activity in black pepper, and as Alice pointed out, that cannabinoids and cannabinoid-like substances in chocolate.
So Alice had mentioned, you had mentioned that basically some of these episodes were up to 16 days for you. And so even after cessating any type of cannabis smoke or ingestion, those symptoms still continued to persist. So I'm wondering, why is it that it takes so long for these symptoms to clear up? Do you guys have any insights as to why that might be?
I mean, I think you can say it better than I can. I know it's THC, just, it stays in your system. It's got a half-life.
So the same reason that you can get pulled over by a cop after not having smoked for 3.5 weeks, and now you have to submit to a UTOX, and now it turns out positive, is the exact same reason that they hypothesize this occurs for many months or sometimes after cessation, and why they want you to go to that full 6-month period or 3 cycles before applying this diagnosis. The lipophilic nature of cannabinoids and cannabinoid metabolites, and that these are being leached into the system at a quantity sufficient to continue to cause illness in these patients.
All right, so this is actually a question that I'm very curious to hear the panelists' insights about. Some folks on the internet seem to be convinced that CHS is caused by the use of pesticides on cannabis. Specifically, they've identified neem oil as a potential causal agent of CHS. So, do you all agree with this idea? And if so, why or why not?
Hell no. Neem oil does not cause cannabinoid hyperemesis syndrome. Now, I know we're not supposed to say anything with confidence because this is still, we're researching it, but I've talked to people who have grown their own cannabis and they have CHS. I tried pesticide-free weed. I have CHS. It's not. The symptoms are similar, but they're not the same. Pesticide poisoning does, it can cause nausea, but pesticide poisoning can also cause seizures and issues with vision. It's not pesticide poisoning. I had an episode from hemp-derived CBD that I know was grown without pesticides. So it's not.
I'm family physician and I like things to be simple. You say kiss. I don't care. I don't care what is the exact reason. I will treat the patient the same way, intravenously, and some things against the nausea. And at that point, of the emergency ward, or the family, or as a primary care physician, I don't care what was the exact reason in the receptors. The treatment will be the same.
I would just add that we actually also have cases of CHS occurring in patients using synthetic cannabinoids. So for anyone in the room who may not be familiar, one of the reasons patients may choose to use synthetic cannabinoids, they may have jobs which require them to get urine tested. 50% of all jobs in the United States require pre-employment urine screening, which is ridiculous. It's an entire industry. But suffice it to say that we have seen CHS in those patients using these agonists at CB1 receptors that may be even more potent than THC. And we have cases going back to 2013, 2014 from England and elsewhere around the world. And also to Alice's point, I know of many cases, not many cases, but quite a few where people were growers themselves and didn't use neem oil and still developed this syndrome. And then finally, to Alice's point, Dr. Ethan Russo as well has spoken about this and how he really doesn't think it's the neem oil because, as Alice pointed out, they're not identical. This is not how neem oil poisoning presents. And when we have seen it, it doesn't persist for this period. And again, we have seen this both in cases where neem oil has not been used on the cannabis and in synthetic cannabinoids.
So moving towards how we get answers and start to pick apart this a bit more. One approach that's been suggested to try and further investigate this is to sequence patient populations with CHS. So are there any different targets that you think researchers might be interested in sequencing to help tease apart what genetic underpinnings might be present in this condition?
Sure. I'll take that. We discussed these beforehand, so I apologize for hogging the mic, but two things we know. In CVS patients, not CHS patients, we have found a gene, the RYR2 gene, and given that I just mentioned at the outset of the talk that we think potentially CHS may even be a subset of CVS, we will certainly want to look at that and see if that's a commonality amongst these individuals who are reporting this entity, and also the cytochrome P450 enzymes that break down THC and its metabolites. Are they somehow different in this group? Are they slower metabolizers, perhaps? These are all targets that we would certainly want to evaluate.
So moving to some of the symptoms and what we see out there, what we're noticing is that hormonal fluctuations in women seem to also worsen the symptoms of their CHS. Do we have any insights as to what is going on here, why this is the case?
Letting the doctor take this one again.
Dr. Dort, do you want to add anything on this?
No.
Oh.
All right.
Like I said, not everyone has the answer. We all have expertise. In our
Well, I
own
mean, we
different
just know
areas.
what's happening. We know that when women are getting their menstrual cycle is when they're having the most severe symptoms. This is a reoccurring pattern. When I had my worst case of CHS, it was during my menstrual cycle, and so. Do you know
We talked about, again, it's going to be along the hypothesis thing where we do know there's involvement of the HPA, the hypothalamic pituitary axis. The hypothalamus is involved in thermoregulation. We think that's gone askew. It's to do with the fact that even every month, women's migraines, their fibromyalgia, all of these things may be worse in the perimenstrual period relating to the effect of estrogen and progesterone fluctuations. We're again hypothesizing that this is having some effect on our homeostatic system, our endocannabinoid system. But again, this is all just hypothesis at this point. And as Dustin Sulak had just mentioned in a prior case, we don't have great data yet on cannabinoids and the sex differences, but it is certainly an area ripe for exploration and investigation.
And speaking of data, Alice has been very active in the community on social media, and she actually runs a couple of different groups to support CHS patients and people who are going through the condition. And she's actually she's done patient surveys. So she's actually gotten response from now 200 patients with CHS, all through Facebook, maybe a couple other sources. I'm not sure if it was just
Facebook.
limited. So again, the power of social media, I alluded to this earlier in my heavy metals talk. It's a really useful tool, and so we're going to go through some of those in just a minute here. So Alice, I will let you click through the slides here. So that should take you.
Okay, so yes, that is, yeah, I've collected data from 200 people. Now, a lot of these people, they find me because I'm doing interviews a lot. I have spoken with Business Insider, Leafly, Rolling Stone, and you know, a few smaller publications as well. And so these people, they find me, they hear about my story, and then I recommend these Facebook groups. And there's people who run other Facebook groups as well. It's not just me doing it. I can't handle all the emotional labor, to be honest. So there are other people that are helping do this. And so out of the thousands of people in these groups, I've collected data from 200 of them. And so, barely. So 75 people were using cannabis for 8 years before the symptoms began. So that is a high amount of people. But as you can see from that, it kind of varies of how long people were using. I'm gonna move. Okay, musical chair so I can see better. Yeah. Perfect. And one thing I want to point out with this data is there's no consistency with anything. It's all over the place. So out of how much people consumed, 55% used it multiple times a day, 27% used it actually all day long, and then some people used it daily, and small amount used it once a day. And the age of consumers varied, with 50 patients aged 21 to 25. And then there was a variety of other ages, but the 21 to 25 was the majority of the 200 people. Then location. Where are all these people that I'm talking to? California had the highest amount of people, 15%. Next up was Canada, 13%. Then New York, Florida, Washington, and Australia. And then there's a small cases reported throughout all the states, and then in Italy and the United Kingdom as well. And I think that we are seeing these stats because this is where people are figuring out that they have it. These are states that are legalizing, and so people are figuring it out versus the illegal states that it's not talked about, and people aren't using high potency THC. They're not using as often due to lack of being able to get it. So then the methods of using cannabis. The highest amount of people were using a bong. People were smoking out of a bong, joints, blunts, and a pipe. Smaller amount were using edibles. 65 people out of the 200 were using vape pens, and 61 were using dabs. So it's kind of all over the place of how people were using before they got CHS. Next up, the symptoms. As you can see, almost everyone out of the 200 had nausea. And then following that is the rest of the symptoms that were occurring: vomiting, abdominal pain, some body pain, diarrhea, dehydration. The list goes on of awful things that people experience with this syndrome. What provided relief? Hot baths and hot showers worked for 157 people. Capsaicin cream for 43. IV was very helpful, heating pads, and ultimately sleep. Some people were able to just sleep through this and try to get relief that way. The length of symptoms after stopping cannabis use. 22% went more than a month of still experiencing symptoms before they got better. So imagine you stop using the one thing that you think helps you with all of your nausea and all of your pain, and you stop using it and you're not getting better. After a month, you're going to think it's not cannabis. So people end up going back to using it again. So next, when asked if running provided relief, 10%. 20 out of the 200 find relief from running. And then this is something we hadn't talked about yet, gallbladders being unnecessarily removed. Since doctors don't know about this, they're misdiagnosing people, and people are having organs removed. 16 people out of 200 had their gallbladders removed and didn't get better, and then ultimately discovered that this was cannabis making them sick. 16 people. And then another 16 people, their doctor suggested that they have their gallbladder removed. And this is out of just 200 people that I've spoken to. Imagine how many people have had surgery that they didn't even need. Pre-existing conditions. And this is something that I find very interesting, is 48.5% of the people who have CHS had anxiety, and some of them were using cannabis for anxiety and depression as well. So a lot of people did have pre-existing conditions, and I think this might have something to do with this, our genes, or I don't know. It's
the gut is the second brain, right? There is more serotonin in the gut than there is the brain. So that could certainly play into this, because of course we know serotonin is very implicated in anxiety. But I'll let you continue.
And these people might be on medicine as well, and we don't know how medicine reacts with THC. I mean, there's not enough research at all. So medicine and the interaction could also play a part in this. We don't know. So in summary, more research needs to be done. And that's it. More research needs to be done.
Yep, and that's the point of having this discussion, is so we can bring more awareness to this topic so that people do start to investigate this a bit further. I want to give a thanks to our panelists for their participation today.
Thank you.
Sharing their knowledge with us. And now I'd like to open the floor to any questions you might have for myself or the panelists.
So where are we on the sequencing of receptors in this family, such as TRPA1, TRPV1, CB1, CB2, et cetera? Are we seeing potential polymorphisms in those in this population?
That's a great question. To be quite honest, that work hasn't been done yet, and that's what we're hoping to, I was actually approached no later than today to get involved in a project that will be hopefully looking at these very things. So we're just getting around to it now, but really the TRPV1 receptor and, to your point, the TRPA receptor hadn't been looked at. Up until recently, people were thinking this was all to do with CB1. But in the past couple of years, as the TRPV issue has become more prominent, given the capsaicin, the showering baths, the running, now they're just beginning to look at that. But certainly that's the next work to be done.
So there's a whole vocabulary list of these TRP receptors, right, that were very much in vogue a decade ago. They've kind of, the field is, the neurobiology field has moved on because it was well exploited. It's the cannabis field now that needs to come into focus with this. So, as I said, there's a large vocabulary list of them, and I wouldn't necessarily just stop at A1 and V1.
Oh, 100%. The endocannabinoid system is exceptionally complex, and there's so many things you could focus on, but I think these are good starting points, and certainly to look at the rest of the TRP receptors as well.
And I'd also like to point out, I'm pretty sure this is the first CHS panel to ever happen. This isn't a topic that is talked about at all, and so we are just now starting the conversation.
And just two quick statistics I'll throw out at you. The overall incidence in Colorado of seeing patients present for nausea and vomiting is 0.07%. This is a small issue, so to put it in context, but it's a very important issue, particularly if you're the person suffering from it or you know someone suffering from it. The other thing to point out is after the legalization of cannabis in Colorado, the following year they saw an 8% increase in presentations to the emergency room for nausea and vomiting. So again, it's only 0.07% of all of their visits, but they did see that uptick. So, we owe it to ourselves to remain intellectually curious and to ask these hard questions.
Since the TRPV1 receptors are involved, is anybody looking into using CBDA to stop the symptoms?
So no one is looking into anything with CHS. Let me just make that clear, is no one is doing research at all. Canada has allocated $250,000 towards the research of CHS, but that is not going to start until next year. No one is putting too much focus on this because there's other things going on in the industry and people don't think that this is a widespread problem. So while we think it has something to do with the TRPV1 receptor, we can't speak with certainty. We don't know.
I will add, I'm aware of a friend of mine in Canada who's looking very closely at the TRP family of receptors and at this thing. But Alice's point, this is more nascent knowledge and a more nascent direction. But certainly there are people already beginning to look at this quite heavily because mechanistically it explains what's going on much better than the CB1 predominant theory, which didn't explain why only certain subsets of patients develop this. There are patients who will use cannabis every day of their life and will never develop this. So what we're really interested in finding out is who is the cohort? Why is it that certain people, and with regard to CBDA as well, I think the patients after they go back and try CBD and have this 16-day protracted period of throwing up are so like, I'm done. So they're not really...
be a guinea pig anymore. I can't be a guinea pig. I've tried and I almost died. So.
But certainly a great question.
Thank you.
Two questions, actually. One about sedation. You mentioned that that helped, or at least sleeping helped. Do you think sedation over a period of time actually decreases the length of the attack? Or do you have a clue?
Dr. Dorr.
I'm not sure.
Go ahead.
Maybe I'm not sure I understood completely. Do you mean to put a patient because of vomiting under full anesthesia and to leave in that for several days or weeks?
Well, I'm not quite sure how the sedation comment that the other doctor made works exactly, but I presume that as you sedate the person, at some point they stop vomiting.
Yes, that's right.
And now there's degrees of sedation and all that.
Yes.
But my question was more along the lines of, if sleep helps and sleeping pills or whatever, does it actually, or do you think it could compress and kind of lessen the severity of the attacks? Like 16 days might shorten to whatever. That was...
Potentially. I mean, I think it's a great question. Basically, you're asking if someone comes in, we have 100 patients, and we sedate them with some benzodiazepines, is their length of protracted vomiting shortened, somehow improved by the sleeping? It's a great question. I don't think anyone has really looked at that, but certainly something to keep in mind. And something that just came to mind as I was talking. Again, Ryan Marino, who's a pretty prominent toxicologist, emergency room physician, and other physicians have recently started proposing keeping a registry on cannabis, given how much of the United States has now legalized cannabis, and in Canada as well. So toxicologists who are emergency medicine fellowship-trained experts in drugs are now going to be keeping a database and asking the same questions every time, so that hopefully in 5 years from now, we will have much more dynamic data.
Sure. The second question had to do with at what level, once you had an attack, what level stimulates another one, like microdoses, for instance. At what level does that kick off an attack? Or, I mean, I think Alice mentioned that just secondhand smoke would do it. Does anybody have a clue about that?
So it varies from person to person. There is no consistency for, I was just consuming like 5-10 milligrams a day, maybe smoking half a joint. And to me, that's not a lot. To someone else, that might be considered a lot. So as far as using again and getting symptoms again, it completely varies for each person. Usually after taking a break, people can consume a little bit over a few months, and then the symptoms come back. So people do try to use it lightly. Also lightly depends on what they think, but there is no consistency.
And one of the slides that wasn't included in Alice's talk today, but I certainly encourage you when she releases all of it to check it out because it's really fascinating. But in that, one of the slides that wasn't shown, 50% of those 200 patients were able to go back and use cannabinoid products again, at least per their reporting. How much of that was true? Was it really 50%? Was it more like 30%? And the other 20% did get sick, but they didn't tell us. But at least 50% are saying that they were able to introduce cannabis or cannabinoids after a certain period of cessation. Then now, where the money is, what was that period of cessation? What were they using? What did their genetics look like? Did they really have CHS? Were they a CVS cohort that stopped for a period and were given that diagnosis? So these are all fascinating questions, but even in talking to other pretty prominent cannabis clinicians at this event, they have noted the same thing. And I would also make the point that some people believe this only occurs to recreational users who dab and whatnot, and that is not the case. We also see this in some medical patients who may only be using for as little as a couple of years in some cases before this develops.
And to follow up on that, so you said people do go back to using, but from my data, people after taking a break, did the symptoms come back? It was 50% of people who started using again, their symptoms did come back. So 50%, just to clarify that, 50% of people who took a break and then started using got their symptoms again. So that's 100 people out of 200.
And then that also raised the question that the other 50% may have been cyclical vomiting syndrome, where they went and smoked again and they didn't have the issue. And that's kind of what this latest paper by Kathasan is getting at, that we really want to be careful here in disentangling these two entities and in prospectively applying this label of CHS.
Just about one point, you asked about second-hand smoking. I don't believe that that will give the patient enough amount to influence, no.
Well, you and I can go sit in a room and you can smoke a joint and watch how sick I get the next day because it can make me throw up. I went to a Snoop Dogg concert and that was a mistake. So I encourage you to smoke a joint around me so you can see what happens because I am that sensitive to it now. And trust me, I wish this wasn't true because I love cannabis so much and I can't go to these events.
I disagree at a certain point. Maybe there are some sensitive persons, individuals. It's always been like that. But mostly second-hand smoking is not effective, no.
Next question.
Hi, thanks. Tom Young from San Francisco Bay Area. I have a patient who was pretty much a recreational user. He was 19 years old. I inherited him, actually. But he was also suffered a traumatic brain injury about a year and a half ago. And so I've been a little liberal as far as not kind of loose on his use, you know, because it had sort of alleviated a lot of his anxiety and insomnia symptoms. But for the last 3 weeks, actually almost a month, he's been waking up every morning with this exact same syndrome. And, you know, I've urine tested him, I've quantified his cannabis use, I've checked, you know, all the usual stuff, you know, including thinking it might be a gallbladder, very unusual for a young 19-year-old man. But I guess my question is, what would you suggest algorithmically or, you know, in a differential where I go with this at this point?
I mean, he needs to take a break, ultimately. And, you know, I think something I didn't touch on was the fact that I have had every test done on my body possible to make sure that nothing else was wrong with me. So I encourage you to look into other things, too, and not go straight to it's cannabis. But I have been poked and prodded over and over and over. So that way I knew it wasn't anything else that was happening. There is prevalence of it being in the morning when people get the worst symptoms, and I don't think we touched base on that question, but it is a very common thing with people who have CHS to feel it the worst right when they wake up. And Tom, do you want to go into explaining that, or just
cortisol? Okay, so when it's time to get up in the morning, the sun coming through your window causes your body to produce cortisol. It's why we see more heart attacks in the morning. We think this is going to be due to a leaching effect from the release of from the release of cortisol, basically causing the leach of whatever retained metabolites and cannabinoids are in the system. Again, just hypothesis, but that would be the leading hypothesis.
So, yeah, he needs to take a break. Needs to cease cannabis use for a bit to see if it was that, because if he continues to use, then it could get worse if it is cannabis. And, you know, I'm not a doctor, and so I'm just saying from what I've seen that it's best just to take a break.
The other thing I would talk about, which is mentioned in a lot of the literature in wanting to bring this entity to the public's consciousness, is that these patients run up $70, $80, $90, $150,000 worth of medical bills when they could just have stopped smoking. They are getting CT scans. They are getting ultrasounds. Sorry, Alice. And I'm a radiologist. I love the business. Keep it coming. But, you know, like really, no. Okay, where I come from in Ireland, you have to be practically dying to get medical imaging. In this country, I've got abdominal pain. Run them through the tube of truth, the CT scanner. That's a problem when a 24-year-old has now had 8 emergency room visits and 8 CT scans and then develops lymphoma 20 years later. These tests are not innocuous, so are benign. So I would simply say, you know, if you smoke cannabis, or use cannabis in any capacity, cannabinoids, be honest with your physician. If you can't be honest with your physician, find a new one.
Thanks a lot. Appreciate it.
And if I may add, if a patient asks for cannabis after having such side effects and insists on having cannabis, then I believe that that is some kind of addiction and he must be treated in other direction.
Yes, I've spent 40 plus years as an emergency physician, and Alice, I have to apologize for not knowing anything about cannabis for 35 of those years. I've seen an evolution, though. It seems like if you come in with nausea and vomiting and you have so much as smelled the flower, there's now cannabis hyperemesis. But, you know, I thought I had a handle on it. This is the first time I've heard that you actually have had recurrent symptoms with CBD, which I'm surprised. I presume that, you know, the association with the high frequent use was because we downregulate our endocannabinoid system. We basically get a dysfunction, acquired dysfunction, and so we develop these symptoms. And that's also why things like the capsaicin, you know, working on other receptors, which again, CBD works on the TRP receptors. Why did it cause those recurrent symptoms? So I just want to have a little more theory about, you know, what is that dysregulation in the endocannabinoid system that might be an underlying cause of this whole syndrome? Yeah, so first off, thank you for your long-time service in emergency medicine. And, you know, it's better to come to cannabis late in life than to never come to cannabis at all. So thank you for that. But what I would say there is why the focus is on what they think is going on at the TRPV receptor is they think it's been desensitized, where we know that it responds to acids with a pH of less than 6, cannabinoids, nociceptive heat at 41 to 43 degrees, and capsaicin. And the idea is that when the cannabinoids can no longer tickle that receptor or get it to provide a certain tone of anti-emesis, that the patients have figured out how to self-medicate or how to self-treat to achieve this. And even in the case Alice was describing, where the gentleman developed rhabdomyolysis from running for 10 or 15 hours, in the hospital, they had to ask him, you know, to stop running in place. And there was another case where a patient in the hospital, the nurses would ask him to come out of the shower so they could evaluate him. So this will just tell you that when the dysregulation goes awry at this receptor, these patients will do anything, to the point where they're coming in with third-degree burns, self-induced from staying in the shower or bath for protracted periods.
I believe we have time for one more question.
Oh, they wanted to go home.
Hi, I'm not sure if I really have a question or not, but it may come out. Like 10 minutes before the panel started, I introduced myself to Alice and said hi. We have a mutual friend by the name of Kristen Yoder who is on LinkedIn. And Kristen Yoder was someone who actually brought this particular topic to the forefront of the cannabis community a few months ago. And boy, the backlash of people in the cannabis community, instead of coming together and being loving, there was all this, really? Are you sure? Isn't it in her head? Are you sure it was this, that, poisoning, whatever? And people were really not very supportive. So I'm here to support you, Alice, on your journey. I know it has not been easy. And
Thank you.
You're welcome. You're welcome. And I really appreciate from the bottom of my heart how grateful I am that you were so vulnerable and willing to be so courageous to the group here today. No matter what the size is, what matters is moving forward and getting this out to the people, because there are other people who are suffering, and sadly, God forbid, if you have this syndrome, it doesn't sound like it's a wonderful thing, but it sounds like there are options and alternatives. And I just wanted to also say that I had my gallbladder taken out, and when I saw that, I'm like, oh my gosh, I really wonder. But nevertheless, like I said, I really don't have a question. I'm here to support you, and thanks for everything.
Thank you. And I would like to just give a few final statements. The person she mentioned is one of my best friends who has my back on the internet. I do get a lot of hate for talking about this syndrome. People have accused me of working for the feds. People say that I'm trying to make cannabis illegal. And I'd like to remind everyone that alcohol is still legal. So this isn't a movement towards getting cannabis out of the hands of people. I am 100% pro-cannabis. I fully believe in the power of the plant. It helps so many people every day. This is just an unfortunate side effect that happens. You can have too much water, and you can have too much cannabis. And so I just want to get to the bottom of it, and hopefully you guys can help me do that. Thank you.
Want to say thank you again to our panelists, and thank you all for attending CannMed 2019, and enjoy the rest of your evening.
Thank you.